All right, going to go ahead. So again, thank you for joining today. My name is Megan Maddox, work at PCC, and I'm going to start with some housekeeping items. So myself and I have two other PCCers who are joining me today to help you, Tim Proctor and Jim Smith. Between all of us, our goal today is to answer any questions that you have around the information blocking regulations that go into effect on Monday. So the way today's presentation will go is we'll do the presentation first, but try to leave as much time as we possibly can for questions and answers from you all. So with that said, you have been muted on entry, but please use the Q&A function at the bottom of the screen and enter your questions in there at any time. We'll queue them up and then we'll get to that after the short presentation. If we don't get to all of your questions, we will have the ability to follow up with you afterwards. So rest assured, we want to answer everything and do everything that we can to help you prepare for the new regulation. Last couple more bits of housekeeping. We are recording this, so you will get a copy of the recording. It will be accessible later, as well as the slides. And there's also one, I'll give a plug for one other recording that's already out on Learn, and that's more of a full introduction to the rule for you all. So last housekeeping item is a small disclaimer on the screen that you're looking at, that this presentation is based on the interpretation of PCC staff, not meant to serve as legal advice. So with that, let's look at the agenda. All right. So first, we'll do a definition and overview of what information blocking is. But then we'll go into ways that how you can prepare your practice for this. Then I'll turn it over to Tim, who's going to talk about PCC EHR functionality considerations. And like I said a few times so far, we're going to try to leave a big chunk of time to do live Q&A. So let's start with that definition. We're going to go back. This is a quote, a pieced together quote from the actual statutory language of the 21st Century Cures Act that was passed into law by Congress back in December of 2016. Massive piece of bipartisan legislation with one section called information blocking that is really there to further interoperability, patient access to care, and the like. So I'll read through the definition, which I keep referring to as the anchor, as all of our questions continue to arise and will continue to arise. So in summary, information blocking is a practice that is likely to interfere with, prevent, or materially discourage access, exchange, or use of electronic health information, unless such practice is required by law. For example, HIPAA. This doesn't supersede HIPAA, or it meets an exception established through rulemaking. And we'll touch on that a little bit too. All right, so why did Congress take this huge action? What's the intent behind this? Because the intent of it is obviously good. So it's to provide patients access to their health information, and as such, increase that data sharing between and among providers. So there's more of a shared decision-making process out there when it comes to individuals' healthcare. It's also to promote competition in the marketplace. And all at the center of everything is the patient and improved healthcare outcomes. All right, so as I mentioned when I was reading through the statutory language, Congress tasked the Office of the National Coordinator for Health IT, which I will refer to much easier throughout the presentation as ONC, to define when it's okay to block information, because there are certainly circumstances that warrant it. So they defined 8 exceptions when it may be appropriate to not comply with the rules or alter the way in which EHI, electronic health information, is accessed, exchanged, or used. These are put into 2 buckets. The first set are exceptions that involve not fulfilling requests, and those include preventing harm, privacy, security, infeasibility, and health IT performance. And then there's also exceptions and procedures for fulfilling requests to access, use, and exchange EHI in a different way. So that includes content and manner, fees, and licensing. And content and manner, just a note on that, that's a more fancy way of saying the what and the how. So the content is what is being requested of you, and the manner is the manner in which you would fulfill that request. All right, next, we're going to talk about how to prepare, things that you can do now or likely already have been doing to prepare for the compliance date that starts April 5th. So this is purely a PCC recommendation, is to appoint an information blocking officer. This is not a requirement of the regulation like it is for HIPAA. So that's per law. This is just a recommendation on our part because it's ideal to have that point person in your practice or your organization to review and update policies and answer questions. You also want to review the aforementioned information blocking exceptions and define policies to use them, determine where and how those exceptions will be documented, logged, and retained. You also want to teach everyone in your practice and organization how to recognize and act upon a request to access, exchange, or use electronic health information. Both formal and informal requests count as requests, whether that's through the EHR, verbally, through the phone or a fax or whatnot. It's all fair game. And of course, most importantly, with those policies that you're defining, you want to provide education for any updated new ones to all of your staff. All right, so there are some required written policies. So a few slides ago, I went through the exceptions. There are 8 total. And out of those, not every single one has an exact requirement to have a written policy, and some do. So one thing I am very pleased to tell you is that we are working on a policy outline and guidance that will be unlearned in the next few days. I don't have an exact date. We're working on finalizing that with our council, and then we'll provide it to you. So when it comes to what you must put in writing, preventing harm, security, and privacy. Naturally, these will coincide with your existing HIPAA policies, so it's good to look at those and see where they complement each other. We have additional recommendations that will be in the guidance that's forthcoming around fees for data exchange. So we recommend for you to review your existing fee structure. There is the fees exception to allow for some fees, and some are strictly prohibited. So it's not going to be information blocking for an actor to charge fees for some things, but it is one thing that is crystal clear. It is prohibited to charge fees to patients for their electronic access to their information. Also, you'll want to think about data sharing policies and responding to requests for EHI. So types of requests that are typical and expected response time. And while it's really important to have these policies and have these procedures and administrative functions within your practice, having a policy written on paper doesn't necessarily exempt you from not information blocking. People can still make allegations, but it's still good to just have that well-rounded policy and administrative procedure in place. All right. Also recommend reviewing and having procedures in place to deal with that content and manner. Again, the what and the how, which really goes together with in the feasibility exception. So you simply can't fulfill a request. And then of course, health IT performance. You're going to do regular maintenance on your health IT systems, on your PCC system. We run upgrades on your system. During those times, naturally, you're not going to be able to fulfill requests. So you want to acknowledge that. And then also, I would encourage you, if you have any question about specific circumstances, to always consult legal guidance for that. I also just wanted to mention as a side to think of this as a marathon, not a sprint. It's very similar to when HIPAA came out, right? It was new to everyone. And there's a lot of figuring things out. So we expect that to be the same with this, and we're here to help you. All right, and now I'm going to stop talking for a moment and hand it over to Tim to talk about some PCC specific functionality.
Thank you, Megan. I assume you can all hear me okay? Good. Yes, so my name is Tim Proctor. I am a project manager and consultant at PCC. And I just want to repeat something Megan said at the beginning. The Q&A, you should have a Q&A panel on your Zoom screen here. If you have any questions, feel free to put them in there. We want to take a good chunk of this hour to address specific questions that you have. So in a little bit, we're going to get to some of those questions here. So, but feel free to post those in there. I want to talk a little bit about some specific EHR configuration related to, really, it's information that you're sharing out to patients, whether it's in the portal or the visit summary, and also some configuration and functionality within the EHR related to interoperability and sharing of information. The first thing I want to mention is patient portal configuration. So hopefully if you're using the EHR, you're also using PCC's portal and signing patients up for the portal. There is a configuration for the portal that you'll see a screenshot of here, that where you can specify what you want to display in the portal, what patient information, clinical information you want to display in the portal. So you can specify those data elements. I want to mention here, I want to emphasize that holding back all diagnoses, medications, labs, screenings, et cetera, if you have all of those unchecked or many of those unchecked, you're more vulnerable to information blocking allegations. There isn't anything in information blocking that says that requires you to share all of this information. The regulation is really based on the request from patients. If patients request this information, you are obligated to share that information with them. But I want to mention that as if you have your portal configuration set to not share this information, it's something you just want to consider or reconsider as you're looking at your configuration and thinking about what you want to share with patients. All right, next slide, Megan. So similarly, the visit summary configuration when in the EHR allows you to share what goes on the printed visit summary in the EHR. And just like with the portal, you have the ability to control which data elements you want to see on the visit summary. Any sort of orders that are confidential, and I'm going to talk a little bit about how confidential orders in the EHR, confidential settings in the EHR, anything that's marked as confidential will not appear on the visit summary. So you can mark certain labs, screenings, and diagnoses, for example, as confidential. And I'm going to get to that in a second. But I just want to emphasize that those orders, anything marked confidential, will not appear. Okay, go ahead. Next slide, please. Okay, clinical instructions. I want to point this out because this is a really customizable component, if you will, within the EHR that allows you to specify certain information to share within the patient portal or the patient visit summary. So this is just a screenshot of that portal config with clinical instructions there, a section for clinical instructions. You have the ability to add specific chart note components or generic chart note components to that clinical instruction section, and they will appear to patients. So this is just a way that if you have specific information or discrete areas that you want to share with patients in the portal, it can go under clinical instructions, and that information will go to the portal. And this is configurable by practice. So the screenshot you see here isn't necessarily what you may have in your clinical instructions. You can specify whatever generic chart note components you want to see in that section. All right, next slide, please. All right, so diagnosis configuration. So this is a little bit about whether controlling which diagnoses you want to appear in the portal. So under the diagnosis configuration tool, this is just a screenshot of that, where you have the ability to specify for each diagnosis whether you want it to include on patient reports or include in the portal. And those settings you are allowed to apply that historically throughout the patient chart. So if you change this, you have that functionality to apply that historically throughout the chart. So this is for diagnosis configuration, and that's the ability to as a I guess a persistent setting for that diagnosis, to have it automatically not set to be included on reports. You have the ability, when you're charting a visit and charting a specific diagnosis within a visit, to change that on demand individually within a visit or for a specific diagnosis for a patient. But this is a setting where you can have that set globally for that diagnosis as a default. Okay, next slide, please. All right, in a similar way for lab configurations, any lab orders that you have, there's a configuration tool where you can specify if you want those lab orders to be included on reports or included within the portal. This allows you to make a specific lab order hidden by default when you order it. And again, you can change this on a per lab or per patient basis as you're going through. Okay. All right. So next slide. Yeah. Confidential notes. So I want to mention or give an example of the ability to customize confidential notes in the EHR. So there, as many of you have in your medical summary, for example, you probably have a confidential notes generic chart-wide note field, and you can see that on the screenshot as the fourth one down there. That is a standard generic confidential note box. You can add and customize chart-wide components and make those confidential. And an example here is one I added called mental health notes. If you want within your patient charts, whether it's in the medical summary or within individual visit protocols, to have a field that has confidential capability. By that, I mean that has a little flippy triangle where you can hide certain notes or display them as you want to. You have the ability to do that within the medical summary and individual protocols, visit protocols. And you can create your own individual components and add those, as I've done here for the mental health notes. This is just a customized component that was added that I've specified is confidential. So this is just a way that where you can, as you're doing a visit, if there's information that the patient has specified as wanting to stay confidential, this is the place where you'd want to put that. That information does not show in the patient portal or within visit summaries that are generated. So that is a place for you to put that and know that it will not be shared within the portal. We're going to get to, I think, some specific questions coming up about in respect to information blocking, what information is okay to not share on the portal in terms of confidentiality and how that really comes into play. We're going to address that here in a few minutes with a specific Q&A here. Okay, go ahead to the next slide. All right, I want to talk about two features within the EHR that are not really necessarily related to clinicians sharing information with patients, which is kind of what we've been talking about so far. This is related to clinicians sharing information, patient clinical data with other clinicians. One of them is direct secure messaging. So this is something that's been in the EHR for a while, and it's essentially a secure email method. And it's a method used to exchange patient clinical data among clinicians. it is, I added a sub-bullet here that it's only useful if you have the direct address for the other clinician, and they also use that feature. So when you're using this, and in the EHR, this is used with when you're generating a health information summary and you want to send that to another clinician, just a summary of care. You have the option to send it, and then you have to specify a specific address when you're sending it. It's not an email address, it's called a direct address that is part of the network. So you need to know that clinician's special direct address to use this. But if there is a clinician that you're sharing information with on a regular basis, or another practice that you're sharing information with on a regular basis, this, and you know that they're part of this direct network and they have a direct address, this can be a really useful tool for sharing information, because it allows you to share not only the summary of care, the CCDA, but other documents to clinicians. You can share PDFs and images and so forth. So we've had the ability to share CCDA and the summary of care for a while, but I think it was fairly recently we added the ability to share other documents. So when you go to send a summary of care, you can now attach PDFs or images or documents related to that patient to go along with the message. So that is functionality that you have there. And that is a benefit of direct secure messaging, in that it's not just restricted to summary of care, it's other documents can be shared back and forth here. And it is a back and forth. So I've talked about the sending from the EHR, but you can also receive a summary of care from another clinician. So with DSM, direct secure messaging, you have the ability, or you have your own direct address. If you give that to another clinician, they can send a message to you with your direct address. And those messages could be a summary of care for one of your mutual patients, or images related to that patient, or PDFs, or any other documents. So you have the ability to receive those on your messages queue in the EHR. I want to be clear that this is not a required functionality within info blocking regulations. So there isn't anything that says, oh, you need to be sharing or participating in direct secure messaging, or sharing your messages with other clinicians, or responding to messages, and so forth. So this is not a required functionality, but I bring it up because it is a really cool feature in the EHR that allows you to share messages with other clinicians. And I just want to make sure everybody's aware of that. Okay, next slide, please. Clinical document exchange. So this is another method. It's similar to direct secure messaging, but a little different in that you have the ability to share summary of cares for patients. So patient summaries, CCDAs, with other organizations that are part of a network. The difference, the biggest difference I would say with CDE versus the direct secure messaging is that practices that are part of this clinical document exchange, or part of this care quality network, this national care quality network, once they enroll in that and are configured to be participating in that, it's an open exchange of clinical data. You don't need somebody's address, for example, to be able to send them information or retrieve information about a patient. Just by participating in the network as a practice and as a clinician, you have the ability to share that patient data. So this is a feature in the EHR. There's a responder role. There's two roles, or two parts of this. The responding part is available in the EHR, and it essentially allows you to respond to requests from other organizations. So another organization, like a hospital or another practice, may send you a request for patient information about a mutual patient or a shared patient. The responder role allows you to share that information in that network. It is a longitudinal summary of care that is shared. So it's like the full patient-wide summary of care, including the summary of their information, medications, allergies, diagnoses, problems, and so forth. So that information is shared as part of this network. There's an initiator role, which is really from your practice. If you wanted to query information from another practice or another organization as part of the network, that's the initiator role. We have that out in a couple practices in a pilot testing stage right now. So this isn't live or something that we can set up with everybody, but we soon will be able to do that. This allows you to retrieve documents, whether it's patient summary, patient-wide, or encounter-based summaries of cares, and be able to request those. Those are the types of information that are generally part of this network and are typically shared. Again, this is not a required functionality within info blocking regulations. I want to be clear on that. You don't need to be participating in this network to be as part of the info blocking regulations, but I bring it up as a strategy or a tool that allows you to share information with other clinicians. Okay. All right, so I'm going to turn it back over to Megan at this point, and we have some leading questions. I see there's a ton of questions coming in the Q&A panel here, and I'm going to refer to those in a second here and start answering those. But we have first just some leading questions. So Megan, you can take that and run with those.
Okay. All right. So these were a few pre-submitted questions. And the first one is, can you give me a real life example of EHI, or electronic health data? So electronic health data means health information that includes patient demographic information, clinical health information. Think of anything that's on your summary of care today, of your CDA. What the ONC did with this rule was they took the common clinical data set, which is, again, what's included on your summary of care now, renamed that to it's a mouthful, United States Core Data for Interoperability, USCDI for short, and it added some fields in version 1. And also, there's going to be new items added to that on an annual basis. So that's a little bit of a tangent, but EHI right now is defined as those elements that can be sent electronically in those data sets. And specific examples include lab tests and values, vital signs, smoking status, allergies, and medications. Our question number 2 here, are records on a thumb drive or disk considered EHI? So data, it's our interpretation that data that requires manual intervention, so printing to a PDF and then sending, faxing, placing documents on a thumb drive, are not EHI in this context. It's a wee bit more complicated than that, because you may find yourself in a position where you're not able to send something electronically that's been requested, but you're going to fulfill that request by printing it to PDF and sending it that way. So again, I always bring myself back to that anchor of this is to increase data exchange, and that's the intent that we should all be striving for. Okay, could you explain what an API is, generally how it works, and how it may be beneficial to patients? So API is short for Application Programming Interface, and it's an intermediary software that allows two programs to interact with each other. So we use these with our banking apps, for the bank to talk to our smartphones and things like that. It's not just limited to healthcare, but it is also heavily used in healthcare. An API, we could also say, is used to transmit data to and from an outside lab vendor or hospital. So this rule, again, is focused on increasing sharing information and patient access to it. So it intends to expand API's usage such that patients will eventually be able to use an app of their choice. This is a long-term goal of the rule, and have all of their health information on their smartphone so they can access their complete health record and, again, be an active part of their care. So it is correct to think of this as the essence of interoperability. When patients and clinicians use and share health data as they wish, and it flows, it's about data liquidity is also a term that's come up a lot, and it flows throughout the system. All right, next. Our clinicians store confidential information in various places in PCC EHR. Do we need to make all of those notes available to patients? So I went the HIPAA route with answering this. The information blocking rule does not supersede HIPAA privacy and security rules. And it's not a requirement of the rule to release all confidential information available to parents or their guardians. Also, it's worth noting that it doesn't, while you can absolutely choose to proactively share information that might then reduce the administrative load of requests on your practice, that's not a prescriptive requirement of the rule. You will see, I got an email from my local hospital that they are taking that route. You certainly can, you don't have to, again. Okay. Now, next one. If a parent requests their child's entire health record to be shared electronically or via paper, am I required to share clinical notes from specialists or hospitals that were included in the patient's chart? So my interpretation of answering this was providers and practices should share patient data that is clinically relevant and has been requested. Requested is a key term in that answer. You know, this doesn't replace HIPAA and the minimum necessary rule. I also think about physician burden and getting too much data and it not being relevant to the goals of the patient and the clinician. We all want to be good citizens out there and share what's going to further someone's health and help it. So if this includes data from other practitioners, then you may share it. Conversely, if the provider believes there's a risk of harm or security when sharing the patient's data, then I would definitely encourage you to review and apply the appropriate exception given the specific circumstances. The net of this all is that there really isn't a definitive answer. What is provided is based on the facts and circumstances of each situation. And I use that terminology because that's the terminology of the rule and what the authorities who will investigate allegations, they're going to look at each situation for the facts and circumstances because it varies so greatly. And I've changed my mindset to look at that as a positive because if things were so prescriptive, it might be equally as hard to navigate this rule. All right, so this next Q&A is from the ONC website. When would a delay in fulfilling a request for access, exchange, or use of EHI be considered an interference under the information blocking regulation? So the ONC's response to that is, it would likely be considered an interference for purposes of information blocking if a healthcare provider established an organizational policy that, for example, imposes delays on the release of lab results for any period of time in order to allow the ordering physician to review the results in order to personally inform the patient of the results before a patient can electronically access such results. And you, of course, you tie into the preventing harm. So it's the way I'm looking at this is a blanket policy of we're not going to release any results for X number of days. That would likely be considered interference when perhaps not all results warrant that extended amount of time before they're released. Oh, that was my last preloaded one. Right here is a list of resources. So there's the final rule in PDF form. It's around 900 pages. So, but I still wanted it there. You can do control find pretty easily for terms if you wanted to look specific items up. Also at the very end of the rule, in the list of subjects, it's the actual regulatory language and not all the commentary that's in the preamble. So I would encourage you to go there if, for example, you wanted to look at the exceptions language. There's also an interim final rule that came out as a response to COVID. And that extended compliance dates both for what we're talking about for Monday's date, as well as dates for the ONC certification program for health IT vendors. When it comes to penalties and imposing penalties, the Office of the Inspector General within the Department of Health and Human Services is responsible for investigating allegations, of course, in partnership with the writers of the rule at the ONC. And they have put out a proposal around that, but nothing finalized yet. I say that with importance because that doesn't negate the fact that this rule goes into effect on April 5th, even though the full penalty structure isn't known. Then the last 3 links down there are incredibly helpful and easier to digest. You've got the ONC Cures site, and within that site, they have FAQs and fact sheets that are, again, very easy to read and understand compared to opening up the final rule. All right, so next, we're going to open it up for Q&A, and just before we do that, we're here to help. If you need more information, have further questions, want to meet with us one-on-one, of course, your client advocate is there, and we are too. And I put our free emails, which we'll keep up on the screen as we do Q&A. So, all right, Tim, you got some queued up?
We do. We have a bunch of questions queued up, and there's some really good ones in here. One other thing I want to mention in terms of resources, Megan shared this earlier. We have a policy, or sort of a sample policy that we're going to be sharing in the coming days that I think will be useful for all of you as you think about some of the policy changes and recommendations that Megan had talked about earlier. We also have an FAQ of sorts that will be on learn.pcc.com in the near future as well, just common questions that we've been getting and answers to those. So we'll address some of them here, but you will also see an FAQ coming up on Learn as well. Okay, so first question, Megan. And sorry, I'm going to look over on my side here. I have a much better screen over here. Will the policy requirements versus recommendations be outlined in this Learn article to be published soon? And yes, I think I just mentioned that. We're going to have some good requirements and recommendations coming out on that article, along with the actual policy, sample policy. Okay, so regarding, this one's about portal messages. So what about portal messages? If there are 2 emails associated with a patient, for example, mom and dad, when dad messages, mom can't see those messages. In divorce situations, many don't want the others to see. Do you have to share these as part of medical records?
I had a client ask that last week, and my understanding was if, the office speaks specifically with dad versus specifically with mom, that's between the 2 parents, or to share amongst themselves, that the office shouldn't get involved in the middle. That this is part of a divorce piece that I was talking with the office, and, the office is there to do the most good care for your child, and that's up to both the parents to share it amongst themselves, not to have the office get stuck in the middle. That was the take of that office manager.
And I think for me, this gets back to what the definition of the EHI is, that electronic health information. Portal messages aren't effectively part of those discrete elements that are part of EHI and that US CDI. So if we're talking about the messages going back and forth between the clinician and the portal account, I don't see those necessarily as being required to be shared. And I don't know, Megan, if you have thoughts about that.
That is exactly where my mind went to actually both of your thoughts. A message between one parent that another parent is asking for, is it relevant to the child's care? My mind goes to intent. I also would throw in there, wouldn't hurt for if legal counsel was involved for that. These are it's another example of there are more questions than answers right now. But the rule does not specifically state, it doesn't address this case exactly. I guess that's what I'm trying to say. But I agree with everything that Tim and Jim said.
Yeah. Another one, is there any way to automatically share all visit notes in the portal other than printing to EHR and importing in and displaying in the portal?
As of right now, there is no easy way to do that, but I know we have an enhancement that is on the table. Just when it's going to be done, I couldn't share with you guys, but you're right. Is there an easy way to do that right now? There isn't.
Will we still be able to lock labs until a physician has had a chance to sign off on them and then make them available in the portal? Or will this be considered blocking?
I can take that one.
Yeah,
I would go right back to this FAQ from the ONC website. That this is very much along the lines of the scenario that the ONC outlines. If there's a blanket policy that imposes delays on the release of lab results for any period of time, that would likely be considered information blocking. So want to rethink that, or to what Tim showed earlier, if there are specific, more sensitive ones that you have clinical case that would maybe go to one of the exceptions of preventing harm, you could take that angle too. But again, having that blanket no lab result would ever be released. The other place that my mind goes to is, again, this is request driven. So if someone is asking for those, that's another element to consider. All right, let's see if I go the right way back here.
Yeah. With confidential notes in a visit, is this something the physician can add during the visit in the visit note on an as needed basis, or does it need to be in the visit note configured ahead of time? My answer to this is, yeah, I think I had showed a screenshot of an example of a confidential note component that I think you're going to want to have that ahead of time. I mean, there is a generic confidential notes component in the medical summary. I think that's a standard thing in the medical summary. But I think I think it would be a good thing to have a specified component within a visit protocol configured ahead of time, and maybe more than one that allows you to sort of organize and organize, let's say, mental health notes versus other types of confidential notes, just so that if you're looking through a visit note, it's easier to find later on. But I think pre-configuring those as components ahead of time makes the most sense to me.
And let me explain real quick to people how that works. When you guys click that flippy triangle down, I call it the grocery list, okay? It's just going to be like your generic text editor that you guys have for components now. So when you do your flippy triangle, you're going to probably want to, as good housekeeping, is put a date at the top of where you're going to start. But you got to remember also, it could be other practitioners, providers, maybe nurses, phone nurses, whoever in the office that adds to that as well. So just to let you know, it's just a running list. I can't say there's a real structure to it where you can say you want a soap note within that. It's not set up that way. It's a flippy triangle, and then it's just a generic text editor, and it's a laundry list. Okay.
Next question, is there a way to make an individual visit confidential? Since confidential notes are chart-wide, this field doesn't really help for those of us who do a lot of mental health visits, but may need to keep those visits confidential in their entirety as one visit of many. So that's a good question. There isn't a way to make an entire visit confidential or mark an entire visit as confidential and therefore not shared in the portal. The visit will still be shared. It's at this time, it's individual components and certain pieces of information that can be made confidential and not shared. But the entire visit itself, you can't mark an entire visit itself as confidential. That is a enhancement request out there.
That is correct. And remember, what's being shared on the portal for the visit is not the whole visit as you're filling out your protocol either. You know, when you look at the visit that's being shown on the portal, it's like your patient visit summary of what went on. It's not going to be your review of systems, your physical exams that you're worried about, unless, like Tim and Megan said, that you set up clinical instructions to go out, and then those pieces will go out onto the portal with that. But, you know, as a good rule of thumb, just remember what you're showing out on the portal for today's visit of your child, say, well, child visit, is the visit summary.
Yeah. Another question is regarding direct secure messaging. When you say you can receive and send messages to other clinicians, does each individual have their own address, or does the clinic have one address?
There is, yeah.
Go ahead,
Tim, if you. Oh, I was going to say that. That's right. We do have one super user that's set up with, say, the DSM, but you can set up multiple people within the practice that have it. Just reach out to your client advocate, and we can start that ball rolling for you guys if you need more than one super user in the office, and we can spearhead that for you guys.
Yeah, my understanding is that each individual clinician has a direct secure address. And I think when you register those, it's on a clinician, individual clinician basis. I don't think there's an address for a practice or practice-wide address, at least not offhand. And
Nope,
I think
I don't. Right, not at this time. Right, that's right.
There's another question here related to direct secure messaging is, how can we tell if the other clinician has direct secure messaging? I know there is, when you're going to send a message, there's the ability to search for other clinicians in that when you're going to send the message. So if you are set up for this on your system, go ahead and try that out and search in there. I know there were, the search results require that the other entity, the other clinician, be part of I think in our case, we use this network called UpDocs. I think they have to be required, they have to be part of that, and that network of clinicians needs to be public and shared. I think from what I understand, there's some challenges with these networks in terms of getting clinicians shared publicly in those networks. Okay. I hear, and the next question is I hear that we have to be able to provide ePHI through an API, application programming interface. Do we have that functionality today? And I can address that. So Megan talked a little bit earlier about an example of an API and what that really is. The EHR does not have that specific functionality today. And by this, I'm just I'll give another example of what this eventually will be, or what this is now in the industry. Is an example of this. The best example is a patient maybe using an application on their phone, whether it's Apple Health or some other application, and wanting to be able to pull in their clinical information from your practice using that app, that third-party app. That's an example of an API that could be applicable to pediatric practices. So we don't have that capability in the EHR right now. It is something that is on our radar, and we've done some research into getting that set up. I can't say it's not on our upcoming roadmap for release later this year, but it is something that is where we feel it will be important, and it's also part of EHR certification. So PCC is no longer EHR certified under the Promoting Interoperability Program for Medicaid. It is part of that certification program, among many other things. We are considering moving forward with that certification for some aspects, some components, and this particular one, the ability to have a patient API set up, is definitely an important one from our perspective. And so it's not something that is out there right now today. Okay, so next question here is, an attorney requests a complete record. Can we send the complete chart through direct secure messaging? The answer to that is no, not through direct secure messaging, because that is clinician to clinician. So The clinician would have to have a direct address. For sharing records with attorneys, that would have to be, I mean, sharing, I don't think there's a way to share that electronically. It would have to be printed PDFs of visit summaries. And I don't know, Jim, if you have thoughts on that.
Well, I mean, the one thought would be is if an attorney is doing it and the parent has a portal account, you could do print EHR and then link it to the patient portal that way, and then the parent can do as they please with that document to get it to the attorney. But also, my take on that would be also that's where Megan was talking about the HIPAA. You still can print it and then charge them a fee for doing that service because it's paper. So you're right. The only other way would be if they want it to do it email to email, you're right, would be make it available on the portal and then let the parent take it from there.
Yeah, and here's a question. Maybe Megan, you can clarify this. Is our practices obligated to send this electronically, like for attorney requests of patient charts, or is generating visit summaries and sending them out? Is that okay?
Absolutely okay. And I would even go so far as to say that when your practice is being subpoenaed, if that's the right word, or asked for this information from a law firm for a case, that's a whole another ball of wax, right? That's not provider to provider or provider to patient. So that I would follow your normal, whatever you do today, continue doing. So that is well, it could be, certainly if you said no, that's a different set of legal ramifications if you didn't respond to a subpoena for information, as opposed to another doctor's request for information. I hope that makes sense.
Yeah.
But yes, to answer it more precisely, yes, you can absolutely still print it out and get it over to them.
Here's another question that came in. So a new practice with PCC says that they came online last summer with PCC, and some of our data that was transferred to our EHR shows up in blocks of texts that are labeled past medical history. This is not protected at this point and contains some sensitive information for some patients. How can we protect that older information? And she goes on to point out that they have good protocols set up in terms of protecting diagnoses for current visits, but it's the old data that they worry about. Old data that are under, that it may be from another EHR under a generic component. So, I don't know, Megan.
I was thinking about that earlier. That would be something I would directly ask your client advocate to help you guys with further direction, because I know when we do these data extractions or brought into PCC, there's some fields that just don't line up, and that's why they get named that, and you're right, and that's out of our control. So to be able to mark that confidential after we've done a data import, that would have to be like an enhancement request, and we'd really have to talk to our development team to say, hey, we need a way, can we hide these,
Yeah, that's a tricky one, because some of that data is, it's data that you'd be perfectly fine with sharing, I'm sure. It's just, it seems like it's a place where a lot of past EHR data, visit data would have gone. So I can't think of a way, like a clear and easy way of going back to separate that out. The only thought I have is as requests are made, like whether it's from a parent, attorney, I realize some charts are long and would take forever to look through, but take a close look through past information with that regard. Yeah.
It's also an excellent enhancement request and something for our data conversion team to think about going forward.
Yeah, absolutely. That's a good question. Yeah.
Yep.
Okay. It sounds like we have about 4 minutes left. There are some questions coming in, and feel free to keep putting them in here. We're not going to be able to get to all of these, but we will be responding to all of these. So I want to make sure people know that, first of all, these handouts, the presentation slides will be shared with everybody if they haven't already been. And we will also go through these questions and follow up with everybody with a Q&A document. Are we required to share consult letters, or should patients go to the original specialist or provider of those consults?
So I answered that. That's one of those use your best clinical judgment. If it's relevant to what you're sending for someone's care, then yeah, you probably should. One of the items that's new in the United States, in the US CDI, in that the EHI outline of what data elements are, is called Provenance. And what that will do is show the author, who the author of it was, as well as the organization. So if you do choose to do that, then the receiving provider or organization will see that paper trail, if you will. But again, if you're unsure, you can seek advice from the person who gave it to you or your legal counsel, of course. Again, it's not clear, cut, and dry as we kind of hoped it would be, but that should help. With 2 minutes left, can I do one more preceded question? Okay, so to get that this is, we absolutely recognize that this is a large administrative and policy lift for you all. There's no doubt about that. But there's also some positive that that you will be able to receive information for clients or for patients who are referred to you, that there will be no, one of the things this is addressing is predatory practices of large organizations who may not be as willing to share because they want to keep revenue, and think of this as a good thing, especially for smaller practices like yourselves. So, yeah. And what, one more question? Anything else? Or 1 more minute for a question?
Here's all right. If we've only had the EHR for 3 years, do we have to provide records prior to having EHR from their paper charts? So I think that's in terms of like sharing information with other specialists. Do they have to provide the records from before they started with PCC, or just the PCC ones?
That is an excellent question, and one that's not specifically addressed in the rule, but I can talk about this. So we talked about that information blocking is limited to the data classes and elements in the US CDI right now. After October 6th of 2022, that expands to be all of EPHI, or really the same definition under HIPAA that a patient would be able to ask for, AKA the designated record set. So we may see it, and by October of 2022, we'll be a little bit more into this and be able to gauge what's necessary, what allegations have come out. So we'll have more information to be able to answer that specifically. Right now, I still go back to that. Is it relevant, and is it useful for the provider or patient who is asking for it? Then the answer is most likely yes.
Yeah. All right.
And real quick, I was going to say, and also, is that paper chart scanned in? That would be another caveat too. If you took the time to scan it into your EHR PCC, I would say then you think it's relevant to share because you scanned it in there.
Yeah. I'm going to throw one last question out because I want to address it. How does a patient electronically share portal info with a specialist? In the portal, there's the ability for patients to share their information electronically with other clinicians via direct secure messaging. So I didn't mention this earlier, but direct secure messaging, once that's enabled at your practice, patients have access to that in the portal too. They would have to contact that other specialist, that other clinician, and get their direct secure address. So that clinician would have to have the address. But that really is the only way that they, and once they have that, when they go to the portal and go to generate visits or go to visit summary and share or generate, they have that option to send a direct secure message to a clinician. So that really is the only way I think that they could send it electronically, that the patient themselves could send it electronically.
That's true.
Okay.
Right.
All right. So we're at time. We're a little over time. So again, we're going to go through the questions that are still here. There's a dozen or so other questions here. We will share a document with some answers to those. I want to thank everybody for coming and coming for this. And again, look out on our learn.pcc.com site soon for example policies and a little bit more questions and answers to some of the common questions here. All right. Thank you, everybody.
Bye.